talk to you about some of the issues in looking at imaging in developing paediatric scoring systems to assess GIA activity and damage, cartilage loss, erosive changes and bone edema. There are 4 hospitals taking part in this part of the project. My own hospital, Great Ormond Street, has studied 93 patients, 52 wrists, 41 hips. 54 patients have undergone subsequent follow-up after the first screening at 6 months, 32 following a year. Enfant Malade in Paris has looked at 96 children, 63 wrists, 33 hips. Year follow-up have done slightly better, 40 wrists, 14 hips. In a 2-year follow-up, 13 wrists and 3 hips. That's quite impressive data. And the Genoa group also working hard, 98 patients, 30 wrists at a year, 17 hips. 2 years, 12 wrists and 3 hips. Bambino Yazoo, who came on slightly later, have had a shorter inclusion period but have done very well, with 45 patients included, 9 patients scanned a year follow-up with the wrist and 2 hips. So a total of 332 patients have been imaged, 227 wrists, 105 hips, 144 patients have been followed up at a year, and 31 patients at 2 years. So let's talk about what we've found in the wrist pathologies in this group. There was some discussion at the beginning of the study what we would use regarding protocols. All patients have a plain X-ray, all patients have an ultrasound, and all patients have a contemporaneous MRI scan and state-of-the-art equipment. We've chosen a selection of sequences, and this was an interesting exercise in collaboration because we have different machines and also we have different expertise, and this was actually a very good learning exercise, and I think can't be underestimated. Getting together with a group of highly skilled people, collaborating, discussing things and coming to a consensus, I think is a very important lesson. I think it's a very important thing to emphasise in an EU project, that people can get together, can cooperate, we can do rather well and learn together, and I think that's a really important thing that we shouldn't underestimate from the study. You can see the sequences I've shown you. On the left is a T1 3D spin echo, T2 faster spin echo FATSAT, and then pre and post gadolinium injection in the study group. You can see very dramatically on this image here, all of the white enhancement is pathological synovial change. So this is a child with a really quite dramatically abnormal wrist affected by GIA. I mentioned ultrasound, and we have some very beautiful pictures. This is the synovium over the wrist, over the lunate, one of the central bones in the wrist, and you can see this very thick synovium, which is very hyperemic, increased blood flow, and we have some very lovely ultrasonographers doing beautiful pictures. And again, plain old X-ray of the wrist showing you collapse of the carpus, really dramatic, quite advanced changes in GIA. What's really important about any of these studies is one needs to go back to Thornbury's model for radiological research. Before we can even think about what is relevant pathologically, we need to look right back to level 1, the technical efficacy, the feasibility of our study, repeatability, the clinical validity and the construct validity in order to improve patient outcome efficacy. And we have to think very hard about this, because to collect data in pathology and then assume that the changes you see are all pathological would be a big mistake for this group of patients. So we had to go right back to technical efficacy and feasibility before we even looked at repeatability. And the way we did that was to look at normal standards. So we had to go back to basics, get a group of patients in whom there was no pathology, volunteers, ethical approval, and scan them. This was done in collaboration across the 4 centres, and in fact recently the group has met. The coordinator of the group, the clinical coordinator, is Karen Rosenthal, originally from Bergen in Norway, but working at Great Ormond Street, and you can see the radiologist named, and in fact Paolo Toma is working hard in the Genoa site as the leader of Clara and Beatrice. So the normal standards, what we had to do was go out and find a group of normal children and had to get ethical committee approval to scan these children in order to ascertain what a normal risk will look like. To do this, we actually sought the collaboration of a site in Norway, in Tromsø, and there we've examined 80 children with MRI, X-ray of the left wrist and with ultrasound. 40 patients, 40 girls, 40 boys, and that's no mean feat, a large group of patients in order to ascertain what normal really is. These patients did not have a full study. It wouldn't have been ethical to give them intravenous gadolinium contrast, so they had a more obtunded, shortened MRI protocol, because really it wouldn't be appropriate otherwise. All of the examinations were looked at by a qualified and experienced pediatric radiologist, and the presence of the abnormalities, inverted commas, or the things that we like to think we see in disease processes were documented, including bony depressions, joint fluid, and bone edema. So, remember, I'm talking about the normal patients now. For the next few slides, I'm just going to be talking about the normal group of patients. These are not patients with GIA, and in fact, Paola will focus a little bit more on the protocol in the abnormal GIA patients. So in the normal group of patients, what was interesting is quite a number of patients showed bony depressions. We like to imagine in radiology that bony depressions represent pathology, and that's not true. In order to get good data, as I said to you, we couldn't ethically go ahead with gadolinium, which is an intravenous contrast agent, to look at synovial enhancement. But in order to compensate for that, we did good quality, thin section isotropic data sets so that we could do 3D modelling of the wrist. And if you look at the control group, in the first 61 patients, if you look at the number of bony depressions, and we're talking about mean number of depressions per bone, the older a child is, the more likely they are to have these bony depressions. So we can't say that these depressions are always pathological. If you look in the 13 to 15-year-old group, there are in some of the bones up to 1.3 mean depressions per bone, and that's quite a lot of depressions. No difference in sex. Boys didn't have any more than girls. And again, you can see more examples, very subtle, but you can see these rather smooth depressions in the bones. And again, here in the lunate and triquetral and in the capitate, tiny little bony depressions, totally normal, asymptomatic children. More normals, again, tiny little subcortical changes, or pits, as we like to call them. So looking at joint fluid, which again one assumes sometimes is pathological, in fact joint fluid is physiological to a certain degree. A certain amount of joint fluid is necessary for normal lubrication of joints. And if you look at the joint fluid distribution in the 61 normal patients, you'll see the distribution really is, there's quite a significant proportion of patients, particularly at the thumb joint, first carpal metacarpal joint, 53 of 61 patients have a moderate amount of fluid. This is what I'm talking about. This is a fast sequence, so it's slightly blurry, but the white fluid is synovial fluid, and this is a normal amount in a normal wrist of synovial fluid. Again, radioulna at the wrist joint, little pit of normal synovial fluid. Bone edema, which again, we often associate bone edema with injury, with trauma, but this was certainly seen in a significant proportion of our normal patients. 24 of 61 patients had some degree of carpal bone edema, and its distribution is shown here. So bone edema basically shows much more prettily on the T2 weighted or the gradient echo sequences, and you can see here the focal area of a higher signal, which is focal edema in a subcortical distribution. More diffuse edema is also seen in the normal group, and here you can see a bone where you have a central carpal bone with quite a conglomerate area of increased signaling keeping diffuse bone edema.